From the Journal of Emergency Medical Services, a monthly publication for EMS professionals, studies have consistently shown only an average of 5 to 15% of patients treated with standard CPR survive cardiac arrest, and providing optimal blood flow to a patient in cardiac arrest by performing quality, uninterrupted CPR is uniformly thought to have a positive impact on improving overall survival. Technology changes everything and every detail of life, and mechanical CPR devices in EMS is the new technology that we need to embrace. Mechanical CPR provides safer working conditions for our EMS professionals, provides better perfusion to the patient suffering cardiac arrest, and ultimately potentiates better patient care and outcomes. Mechanical CPR devices offer a new way of handling one of the most taxing parts of the service we offer to our communities through a technological development that has been a long time coming. Imagine it's 0200 on a Saturday morning and you're on the back side of a 36-hour shift that was only supposed to be a normal 12. You're tired, you can't sleep very deep because you know that as soon as you drift off, that call is coming and your unit is going to be dispatched to something you wish you would have stayed awake and been more prepared for. It happens every time. Ironically, you do the exact thing you were trying not to do and doze off. As soon as your thoughts are turning to those very lucid dreams we all have at the start of sleep, tones drop. Your unit is called. You snap awake and now feel more tired than before you decided to come up to quarters and rest for a little while. The radio advises you. 45-year-old male, no past medical history, unconscious, unresponsive, not breathing. You kick into high gear, preparing yourself for the call we spend years training and retraining for, hoping to do your absolute best to save this patient's life. You hop in your ambulance with your partner and off you go, lights and sirens blaring, hauling ass to the address you were given. You make it on scene just as the fire department is running inside. You're the highest level of care on scene as a paramedic and you know you have to call the shots. You get the story from the fire chief and he tells you the family saw the patient collapse after being short of breath and complaining of chest pain. You apply the pads and instruct your partner to start ventilating the patient while the new guy in the fire department verifies an absent pulse and starts chest compressions. You get IO access through the tibia bone and look up to see that your partner has placed a king airway in the trachea of the patient, confirming a patent airway to ventilate this unlucky man. After 2 minutes of the compressions, you call for a rhythm check and everyone stops, all waiting on you to tell them what to do next. You know that if you see a workable rhythm on the monitor, things just got more interesting, more difficult, and you have to orchestrate the transport of this patient to the ER, while trying to do correct life-saving maneuvers and medication administration, as well as life-saving CPR, all at 80 miles per hour. You think about your partner having to stand up in the back of the squad, unrestrained by seatbelts, performing compressions the best he can, while the ambulance races around sharp turns and does the brake accelerator dance through stoplights and uncompassionate civilian vehicles. You remember the times that both you and your partner got thrown around in the back of the squad. You remember the close calls. You remember doing worse and worse compressions on the patient and how exhausted you become so quickly, threatening patient survivability and you and your partner's own health. You hold your breath as you look at the monitor, searching for the rhythm that says if you will transport or not. And we've all been in this position or one similar. We've all been thrown around the back of the squad while trying our best to perform adequate compressions, correct ventilations, and on-the-money medication dosage administrations. CPR is exhausting in the best of circumstances and can be deadly itself in the wrong ones. No more do we have to be unrestrained in the back of the squad, sweating, panting, hoping and begging that we don't get into an accident this time. Now with the advent of devices like the Lucas II, an automatic mechanical piston-style CPR, we can be restrained by seatbelts, able to conserve our energy and focus on other life-saving techniques and procedures, and be as safe as possible while doing so. All this, and at the same time, our patient is receiving picture-perfect, continuous, uninterrupted compressions, maintaining perfusion to the brain and allowing us to use our resources for patient care in a safe, much less exhausting manner. Safety is key. It's a no-brainer. Per the Journal of Emergency Medical Services, manual chest compressions are often done incorrectly, especially in the back of a moving ambulance. And incorrect chest compressions can negatively impact survival. Studies have shown the correct application of CPR is an independent determinant of survival to hospital discharge. However, 3 human observational studies showed that interruptions of chest compressions were common, averaging 24% to 57% of the total arrest time. Anytime compressions are ceased for any reason, studies have shown that it takes approximately 90 seconds to reprime the heart and build up the necessary pressure to send oxygenated blood to the brain and other vital organs. Studies compared the use of mechanical CPR means to traditional manual application and found that the coronary perfusion pressure maintained by mechanical CPR was on an average of 4 times higher than that obtained by manual means. CPP is what keeps the brain alive, people. Return of spontaneous circulation, or ROSC, is predicted by a CPP of more than 15 millimeters of mercury in humans. And on average of these studies, manual compressions averaged a reading of 5 millimeters of mercury, while mechanical means was consistently reading 20 or higher. Manual CPR has many attributing factors based on the provider: fatigue, physical ability, interruptions during movement of the patient, and differences in training and technique. Mechanical CPR has none of this to worry about. It performs constant, consistently effective CPR with no fatigue or drain on personnel, thus providing constant high levels of CPP and allowing EMS professionals room to focus on drugs and therapies to increase CPP even further. Coronary perfusion pressure, CPP, is what keeps the brain alive. And that's the whole idea. This is what we're trying to achieve. CPP is the end result of what we try to achieve with CPR. With limited resources and the human condition, there's too much variation in manual CPR that even in the best of circumstances leads to subpar CPR. Now, compressions is a small part of the big picture in resuscitation, and it's time that it takes its place. The monitor shows wide complex coarse ventricular tachycardia, a shockable rhythm, a transportable rhythm. You advise your firefighter to resume compressions and announce that you are charging the monitor to shock the patient. The monitor finishes charging and holds its high-pitched tone, awaiting your command to shock the quivering heart of this clinically dead patient in front of you. You clear the patient and make sure no one is touching him, and deliver a shock at 360 joules directly to the cardiac muscle. The patient's muscles contract and then relax. You and your team are ready. You grab an arm of the patient and a firefighter grabs the other arm. While your EMT holds the head of the patient and maintains the adequate airway, you do a perfectly synchronized team lift and bring the patient into a sitting position. The fire department has been awaiting this moment, and everyone on scene has been trained accordingly in this procedure. It's only 3 or 4 seconds since the shock has been delivered, and now you and your team are lowering the patient back to the floor and securing the Lucas II automatic mechanical piston CPR device around your patient. It has only taken 12 seconds from the delivery of the shock, and you press the play button on the device. Perfect CPR resumes, delivering compressions well above the rate and well deeper than the requirements set forth by the American Heart Association. And now it's time to load the patient. You know you have around 2 minutes per ACLS before the next rhythm check, and you go ahead and deliver one of your doses of epinephrine, writing down the time on a piece of paper. You have a moment to reminisce of the times when things weren't so calm, when personnel were a lot more on edge, and when the patient suffered less than optimal care, while your coworkers and yourself were in a much more dangerous position. You load the patient with the assistance of the fire department and get him into your squad without a single interrupted or poor chest compression. It's right on time for another rhythm check, and you pause the Lucas while you tell your partner to cease any contact. You look at the monitor and see refractory ventricular tachycardia. You press play on the Lucas and tell your partner to continue ventilations after he secures the seatbelt. Compressions resume. You charge the defibrillator again, and you secure your own seatbelt and prepare for the second shock. The firefighter asks if you're ready for him to drive the squad to the ER, and you reply, "Yes, please, and be safe. We're okay back here." The monitor makes the high-pitched tone. You clear yourself and your partner from any contact with the patient, but the Lucas keeps right on delivering perfect compressions. You deliver the shock and record the time on your paper. At the same time, you deliver the next dose of cardiac medication. You and your partner are secured. The patient is receiving textbook perfect compressions and advanced cardiac life support care. And the firefighter, and things are going very well for a cardiac arrest anyway. At the next rhythm check, while the firefighter is pulling into the ER ambulance bay, you see that the end-tidal CO2 reading has jumped significantly with your patient, the first sign of return of spontaneous circulation. You pause your Lucas and notice the patient has converted to a sinus rhythm on the monitor. You check pulses, and you find a carotid pulse on the patient just as the firefighter opens the rear door of the squad. We got him back, you say. Manual CPR with 7 nurses present in the ER is a task that requires every person to have a job and to be great at it. Manual CPR with 2 EMS professionals is overwhelming, and the national statistics of out-of-hospital resuscitation show that in numbers. Less than 10% of our cardiac arrest calls regain pulses on a national average. Wonder why there are 7 nurses present in the ER? Mechanical CPR devices free up personnel to concentrate on the other important tasks at hand. Chest compressions are a big part of the ordeal, possibly the most important one to maintain. Why not develop and use something foolproof and human error resistant to handle the most physically strenuous portion of the task? Smarter, not harder, people. Mechanical CPR devices such as the Lucas II allow EMS professionals to remain as safe as possible while transporting in an emergent cardiac arrest situation, maintains more adequate CPP levels at more consistent level, and allows EMS professionals to focus on other key concepts to life-saving resuscitation techniques such as drug administration, electrical therapy, and correct ventilations. Manual CPR was the best we could do at the beginning of EMS, and we perfected it. It is no longer the best we can do with the technological advancements available in this field. It's time we get behind the 8 ball and use this technology to benefit our safety and the survivability of cardiac arrest to our patients. Studies have consistently shown only an average of 5 to 15% of patients treated with standard CPR survive cardiac arrest, and providing optimal blood flow to a patient in cardiac arrest by performing quality, uninterrupted chest compressions is uniformly thought to have a positive impact on improving overall survival. This is no longer acceptable, as we have means to do much better. I call on you and EMS as a whole to make this poor outcome something of the past. We have the means to provide better patient outcomes. We should make mechanical means of CPR with devices such as the Lucas II a standard across our field. Only we can make the change.